So welcome to today's webinar on prehabilitation, optimising patients to improve outcomes. My name is Pippa LeBook and I'm going to be the moderator for today's program. Next slide, please. So today's speakers, we have Dr. Steve Wooten from the University of Southampton, Morten Quist from the University of Copenhagen, and Christina Prickett from Peter MacCallum Cancer Centre in Australia. Next slide, please. So these are our disclosures to the speakers. Next slide. We'll just start off by running through some housekeeping notes. So if you'd like to download today's slides, you can access them by clicking the link to the webpage in the bottom of the chat. You will also be able to access the video recording of today's webinar in the coming week. And you'll also be able to access a link to part 1 of this webinar series in the same link. So that was pre-recorded. We will shortly receive an email to give you instructions about how to obtain your CME credit for attending today's webinar. And throughout the webinar today, we'll be using polling questions for each presentation. So when you're asked, you'll see a box pop up on your screen, and then can you please answer so that the speaker can then use the results to discuss these in relation to the cases. Your camera and microphone will remain off for the webinar, and please enter any questions you have for the Q&A discussion into the Q&A section at the bottom of the Zoom webinar. You may use the chat function for all of the discussions. We're not going to be using the raise your hand function for questions, and we plan to have a discussion and Q&A after the presentation. So please be entering your questions to the Q&A section anytime throughout the entire session. So next slide, please. So just before we get to hearing from our speakers, we thought it would be good just to have a little bit of a look at the background to prehabilitation in thoracic oncology. And whilst prehab is a rapidly growing aspect of cancer care, one of the biggest challenges that faces clinical teams when setting up a program is what should it consist of, who should be involved in delivering the intervention. And despite all the research into prehabilitation, as well as multiple systematic reviews of the findings of the research, and I've included a few of them here for you to have a look at, there's no definitive outcome that has been found about what prehab should look like. So the suggested components, the duration, the frequency, and timing differs between tumour groups, countries, and medical centres and groups. Therefore, there is no standardised intervention that can be replicated. Next slide, please, Aubrey. One of the key differences between prehabilitation programs is whether it's delivered in a unimodal or multimodal intervention. So the majority of the research available focuses on a unimodal intervention, which offers exercise only. And whilst this has been shown to have positive outcomes of improving cardiopulmonary fitness, pre-treatment, and improving stress levels, post-operative complications, length of stay, and quality of life, it does not address the individual holistically to ensure the best long-term outcomes. Alternatively, prehabilitation can be offered in a multimodal intervention consisting of multiple components. An aspect of exercise should always be included in conjunction with interventions to address education, behaviour change, psychological needs, and nutritional needs. This approach has been found to not only have the same pre and post-operative outcomes as the unimodal model, but also to improve nutritional, cognitive, and wider psychological outcomes, as well as reduce stress related to lifestyle behaviour, reduce risk related to lifestyle behaviours. Next slide, please, Aubrey. So in November 2020, Macmillan Cancer Support in the UK published its first principles and guidance for delivering prehabilitation for people with cancer. It was created by a multidisciplinary team of experts, so one of who we're lucky enough to have speaking today, and to look at how we ensure that prehabilitation is addressed from a holistic stance. I'd really encourage everyone, if you're interested, to go and have a look at this. It's easily accessed on the internet. But the key findings of this is really that cancer prehab should be delivered through multimodal intervention, and this must include an element of physical activity or exercise, nutrition, and psychological interventions to ensure that we're addressing the individual both from a physical and mental aspect. The intervention should also be stratified into 3 categories. So it should be universal intervention, which consists of education and advice relating to optimising physical and mental health outcomes, both pre and post treatment. And this can be delivered by either a registered or unregistered healthcare professional, providing that the registered clinician is involved in developing the education materials. Targeted intervention for individuals identified as being at risk of deterioration secondary to performance status or comorbidities, and these should be provided by either registered healthcare professionals or an unregistered healthcare professional under supervision of the trained clinician, or specialist intervention for those individuals who have complex needs or undergoing complex interventions. And this should be delivered by a registered healthcare professional. So keeping this in mind, we aim to complete a holistic look at prehabilitation in today as part 2 of our webinar series. In our first webinar, we focus more so on the background prehab, how do you set up a prehab program, and also looking at the exercise element of this. And today we're going to progress looking at how do we optimize nutrition, function, and psychological needs. So I'll now hand over to our first speaker, Dr. Steve Wooten.
Thank you, Pippa. I should now have control of the screen, we'll see. So I'd just like to thank the International Association for inviting me to talk today. And I'd like to offer a welcome from the University of Southampton and all my colleagues in Southampton who have a particular interest in prehabilitation. What I'm going to try and do today is just talk you through some of the nutritional considerations in the management of patients with lung cancer as part of a prehabilitation program and beyond. And it looks like, here we go, sorry. So for today, my key messages are quite simple. I want to emphasize that nutrition is an essential part of the management of lung cancer and a key consideration in prehabilitation. For many of us, we've been prehabilitating our patients for the best part of 30 or 40 years from a nutritional perspective. And pre-op nutrition and pre-treatment nutrition is clearly a major part of an oncological service. And that's why we have our dietitian, our dietetic colleagues so actively involved. What I want to emphasize is malnutrition is far more common, particularly in thoracic cancers, and impacts on morbidity and mortality. Therefore, what we need to do is identify those most at risk and offer nutritional support. What we know across most cancers is that interventions can improve the experience of cancer and the outcomes to cancer. What I would like to emphasize, however, is that the evidence specific to the nutritional management of lung cancer is far more limited, and I'll raise that in a few places in a moment. Central to a discussion about nutrition in thoracic cancers is this issue around sarcopenia, cachexia, and malnutrition. And I thought I'd just start by just offering a conceptual approach that might help us in our discussion. We know that inadequate food consumption of itself will ultimately result in wasting through a process which we call reductive adaptation. And this happens regardless of disease, and we can think of this as diet-related malnutrition. At the same time, independently, disease and the treatment for that disease of itself can result in changes in nutritional state through specific nutrient losses, cellular damage, and tissue malfunction. So in terms of what we see as the classical presentation of a patient with lung cancer, severely wasted and cachectic, what we have to recognize is not just simply a lack of protein, it's not simply a lack of protein and energy, but there are a whole range of specific nutrients which have been affected by the process of the disease directly altering the way in which the body is working, cachectic influences in determining food consumption, appetite, and nausea, and also the processes through which patients will continue to lose weight. I think it's very important to recognize that even in those who are not wasted and of a normal weight, the disease and its treatment of itself will cause nutritional concerns. These concerns ultimately result in a loss of regulation and control, and with that, decreased resilience, decreased response to the disease and its treatment, and poor outcomes. So when we think about malnutrition in patients with lung cancer, we know from the observational studies that have been made that something like 40%, nearly half of the patients, will have anorexia, loss of appetite, and weight loss prior to diagnosis. In fact, it's one of the most obvious presenting features. But equally, something like up to 3/4 of patients may demonstrate their increasing malnutrition during treatment associated with the disease process. And what we also know is that modest weight loss during treatment, particularly associated with chemotherapy or radiotherapy or the use of biologics now, predicts a poor response to that treatment, poor quality of life, and impaired survival. And if you'd like to know a bit more about this, I recommend Nicole Kiss's paper from 2016, which I've included in the reference list. In terms of the impact on quality of life, the predominant feature that affects patients is cancer-related fatigue. And this is very much associated with weight loss and loss of appetite, and of itself may present before, during, or after treatment. So a simple question for you here. So what I'd like you to think about is the cause of weight loss in patients who have cancer. And I'd like you to think about what the primary cause is. I offer you 3 alternatives here. Increased energy needs due to hypermetabolism of a tumor mass, a loss of skeletal muscle due to disease-related inactivity, reduced energy and nutrient intake due to a loss of appetite, malabsorption of energy and nutrients from food, and muscle protein breakdown driven by cancer cachexia. So Aubrey has put the polling questions up. I'd just like you to indicate what you think is the primary cause from those 4. Sorry, those 5, to apologize. Okay, Aubrey, could we see the results? So here are the results here. So you'll see that inactivity is a malabsorption, are not on, very obviously on the list. We have increased energy needs due to hypermetabolism. When we've looked for hypermetabolism, we may well see an increase in basal metabolism, but that's often offset by decreased energy expenditure and physical activity. And there are cancer cachectic specific responses on protein metabolism, but they're not the primary cause of the weight loss. As you've indicated here, the primary cause of weight loss is the reduction in food intake. I'll just take control back again. And hopefully I can have this back. One second, there we go. So weight loss is primarily due to a reduction in food intake. And this is associated with the disease process or the treatment. It's poor appetite, early satiety, a range of symptoms of the illness specific to lung cancer, breathlessness, impact particularly on feeding, pain, fatigue, inanition due to depression, anxiety, changes. The treatment side effects are very powerful and very impactful on patients' intake. But we mustn't also forget social isolation, life change, and mental illness. And we'll come back to that with Christine a little later. Here we just, and we have a range of symptoms that affect intake, and I've listed them here. And this is across all cancers, but there are specific symptoms, we call them nutrition impact symptoms, that feature in lung cancer, particularly in and around processes associated with the thoracic structures. We can think of these as nutrition impact symptoms, all of which are associated with cancer and or its treatment, and all impact on nutritional state. I think it's important to recognize that these may present before, may present before a diagnosis, may change during the period as up to treatment and during treatment, and may change again after treatment has been initially completed. All substantially impacts on the nutritional well-being of the patient. So what I'd like to ask you is, do you see these symptoms in your patients? Do you usually only ever see one, or do you see multiple symptoms? And if you do, what do you do about it? Colleagues in Australia from Issering's group have looked at the impact of symptoms, because cancer patients, particularly lung cancer patients, suffer from multiple nutritional issues. And there's a clear association between the number of these symptoms and the likelihood of malnutrition. Using a screening tool, which I'll show you in a moment, the patient-generated subjective global assessment tool, they found that about half of the patients had evident malnutrition. And again, about half of them required better symptom management and treatment for their nutrition. Those who experienced the most symptoms experienced the greatest likelihood of malnutrition. And you can see here in those patients who had 5 or more symptoms, then nearly all of them were malnourished. Equally, it's important to note that even those without symptoms still had a chance of being malnourished. Of these different symptoms in lung cancer, taste, appetite, and nausea were the key signals associated with weight loss. The challenge we have is that when we rely on weight, we actually can miss many of the vital signs and symptoms that indicate the patient's becoming increasingly malnourished. We now know across a range of different cancers that the lack of lean, and particular lack of muscle, is associated with poorer outcomes, as shown here in the right-hand panel from Lisa Prado, showing here a normal weight patient, a normal body composition, versus the survival curve of those of a normal weight but sarcopenic. So the lack of muscle is often masked by an increase in fat. The challenge is how do we pick up this lack of muscle? Probably the gold standard is ultimately, at the moment, magnetic resonance imaging, where we can actually measure the volume of muscles and all of the muscles in the body. A lot of people have been interested in using DEXA, where we take a 2D coronal area and derive an estimate of appendicular lean tissue mass, which is a proxy for whole body muscle mass. Others are using routine CTs, particularly taken in an axial slice here, L3, where we can actually make a cross-sectional area estimate of muscle, and from that equally derive an estimate of fat-free mass. And each of these techniques have been used, and each have been associated with poorer outcomes: a lack of lean, a lack of muscle, whether it's DEXA determined or CT determined. For many of us, however, we haven't got the time to wait for the CT to be analysed, and we need to make point of care decisions. So in Southampton, our approach is to use bioelectrical impedance analysis as a marker of the changes in body composition that reflect increased risk. What we also now know is that many of these factors interact with each other, and there's additive effects influencing overall survival. So weight loss, a lack of muscle at diagnosis or prior to treatment, poor muscle attenuation as a marker of muscle density, and if we use bioelectrical impedance, low phase angle. All of these reflect the poor metabolic state of the patient and the increased risk. And if we add those to poor appetite and those nutrition impact factors or symptoms that I described, these are the best markers that we can use to identify patients at risk. So once we've identified our patients, we want to intervene. From my perspective, prehabilitation is very much about making sure their nutritional needs are met, as well as exercise and psychological support. The exercise is critical as providing that metabolic stimulus, and psychological support is needed to influence the patient's ability to address the needs of treatment that we're proposing. And through this, we can improve resilience, response, and outcomes. I would like to stress, however, that cancer cachexia cannot be fully reversed by nutritional support alone. In fact, none of the prehabilitation mechanisms of themselves will influence the degree of or replete muscle that has been lost. What we can do, however, is improve the experience. We can improve the tolerance and the outcomes to treatment. So we need to think about how we're going to identify those at risk and how do we triage them. Well, there's lots of guidance out there, and I've listed a few of them here. I think it's fair to say that the evidence in lung cancer is poor, but I'll try and highlight the critical points we should make from a nutritional perspective. What we have to recognize, it's a cumulative experience, and it's not just about prehabilitation. It's about before, during, and after. And because many of our patients go through repeated cycles of treatment, we have to think about prehabilitation constantly, optimizing patients prior to treatment. As I say, we need to identify the risks, we need to screen them, assess them, and where we can make a nutritional diagnosis. What is it that's causing the problem? Optimize patients throughout their journey so that we can improve their nutritional, physiological, physical, and psychological fitness. There are a range of tools out there. We've looked at most of them over the course of the last 5 years. In the UK, we use a malnutrition universal screening tool, or MUST, but we find that lacks specificity in cancer patients. The European clinical nutrition community have come up with the GLIM tool, again, quite a sophisticated tool to diagnose malnutrition. But the tool that's been the most useful is the short form patient-generated subjective global assessment, both as a screening tool and an assessment tool. The PGSGA has two components, something that the patient can do, shown here in blue, which is a good screening tool, which picks up on many of the factors that we think are important. And then we've got a professional component, an actual assessment of the patient, bringing in the clinical considerations. We can score them into well-nourished, moderate malnutrition, or severe malnutrition. And these have all been associated with mortality, post-operative complications, length of stay, overall survival, and costs of care. So this is the tool that we would recommend people consider and look to see how they might use it in their setting. But what mustn't be overlooked is the role of the dietitian, because although the tool will identify those at risk, you really need to diagnose the nature of the problem. And this is where the dietitian is particularly important. A full nutritional assessment will capture many of these considerations, including the use of supplements. It will look at the nutrition impact symptoms, and it will focus on all the other factors that might influence adherence and willingness to accept perhaps a change during these very difficult times. In the Macmillan report that was referred to by Pippa earlier, we considered from a nutritional perspective how patients with different levels of risk might be managed, from home-based remote support for all patients, that's supportive self-care, largely around advice. For those with identified needs, we recommend the use of dietetic counselling and the use of oral nutrition supplements and addressing the nutrition impact symptoms. And for those who have more complex needs, they may actually require artificial nutrition support, the use of tube or vein feeding. What we know is that the dietetic approach is food first and actually focuses on these nutrition impact symptoms and may use supplements. It's about understanding the nature of the condition, enabling the patient to make the changes and increasing their confidence. We don't recommend large amounts of leaflets because they're largely ignored. We find that peer working, group working is a very effective way of managing larger numbers of patients at any point in time. And we're very popular apps that we're now using are increasingly helpful. And as I say, our nutrition support teams or intestinal failure teams are often necessary. In terms of dietetic counselling, it's start early and continue. Please don't just give a high protein supplement that does not address the nutritional needs of the patient. The number of dietitians that are around is constrained, so it's about enabling others to help. And in terms of evidence of effectiveness, Bagley demonstrated that we can improve intake and symptom control, but in terms of impacting on cancer-related fatigue and quality of life, it's a very mixed message in lung cancer. And certainly where nutritional status has been improved, cancer-related fatigue and quality of life can improve. So it's a bit of a mixed bag, and it's very much about the quality of the intervention that matters. From a nutritional perspective, we do know preoperatively nutrition can improve outcomes. The work of my colleagues in Southampton have demonstrated this over the last 20 years. In terms of prehabilitation, Chelsea Achilles has looked for the evidence for us and demonstrated what is available from the literature in terms of multimodal prehabilitation, and has actually been able to demonstrate from the limited studies that are available to us that there's a 2-day reduction in length of stay when multimodal prehabilitation that includes nutrition has been offered to patients prior to their surgery. What is also important to note is that when we looked at the evidence, and I refer to a paper we've just published with Chelsea, where we did a scoping review of the nutritional interventions, we actually found that they were very poorly reported. It wasn't actually clear what they were trying to do in many of the studies. There was very little information about the delivery of nutrition and adherence to treatment, and very few of them actually changed nutritional state. So what I'd like to leave you with is that nutrition matters, is an important part of any prehab program. Malnutrition is common, it impacts on morbidity and mortality. Whilst we might not be able to fully reverse cancer cachexia, we can influence outcomes and we can influence quality of life. There are lessons from all cancers, but there's far less evidence in lung cancer and more research is needed. We need to think about screening, assessment, and diagnosis. And we need to think about monitoring. I put to you that dietetic counselling and access to nutritional support is key. And nutritional interventions, when delivered well, can impact on perioperative morbidity, quality of life, fatigue, and treatment tolerance and costs. At the same time, we still need more evidence. I'd like to thank you for listening, and special thanks to the team in Southampton that I work with. What I'd like to do now is hand over to Morten for the next presentation.
Thank you, Stephen. And thank you for the organization to initiate this webinar. This is really interesting to have some views on how prehabilitation can work out. Aubrey, would you have the next slide? Because I will start out with the first question here, and I would like to know how many of you know how many patients with lung cancer are ineligible for treatment. Is it less than 40%, 30%, 20%, or 10%? And we should have an answer. And most of you knew it, so it's less than 30%. And one of the reasons I asked this, and I'm just trying to request so I can control this. One of the reasons I asked this was because I would like to show you a way to look at these patients in a different way, and another way to evaluate these patients. And do I have control? Yeah. So lung cancer is one of the deadliest cancer diseases worldwide, and the best chance for cure is surgery and adjuvant treatment. However, more than 70% of patients with lung cancer are inoperable at the time of diagnosis due to advanced stage disease. The 5-year survival rate for patients with lung cancer is generally 16 to 20%, but for patients with advanced inoperable lung cancer, it is an average of 10 to 15 months. In general, patients diagnosed with lung cancer are above 70 years of age, have a low socioeconomic status. They are deconditioned due to an inactive lifestyle. They often experience severe physical and psychological symptoms like decreased exercise capacity, muscle weakness, comprise health-related quality of life, and increased anxiety and depression level. When diagnosed, the stage and histology of the tumor decides what treatment, surgery, chemotherapy, immunotherapy, or radiotherapy patients will be offered. And for oncological treatment within all cancer types, the toxic side effects are common, but patients with advanced lung cancer can experience a higher burden of disease symptoms and treatment-related side effects compared to patients with cancers in head and neck, prostate, breast, gynecological, and bladder cancer. So to evaluate the level of tolerance to toxicity, it must be balanced with the expected toxicity to avoid that the patient have unreasonable harmful side effects to the treatment, which in worst case could lead to the patient dying of the treatment and not the disease. Though it's of crucial importance to access and predict the patient's tolerability to treatment as accurate as possible. To estimate the patient's tolerability to the appropriate treatment, clinicians worldwide use the Eastern Cooperative Oncology Group Performance Score. And it's based on clinicians' estimate on the patient's ability to perform daily activities and their ability of self-care on a 0 to 5 scale. 0 is equivalent with being fully active. Grade 1 is restrictions in strenuous activities, but able to carry out housework. Grade 2 is being up and about more than 50% of the day. Grade 3 is being confined to bed or chair more than 50% of working hours. Grade 4 is completely disabled and confirmed to bed. And grade 5 is dead. And normally when you are evaluated for oncological treatment, patients that are above performance status 3 are usually deemed unfit for oncological treatment. And although performance status is the most commonly used assessment tool in oncology setting and clinical trials for predicting survival and suitability to treatment, studies have raised the methodological concerns about the reliability of the scale. Because the performance status scale is not, sorry, one study raised the concerns about the performance status scale not being able to predict toxicity to antineoplastic treatment accurately, and points out that the performance status scale is based on work from the 1940s and has remained unchanged since then, despite major advances in cancer treatment modalities and changed safety profiles of the drug. Another study reported that the accuracy of the prediction also depends on the oncological experience of the healthcare professionals, and additionally, interactions between patients and healthcare professionals can really influence the clinical evaluation of the patients. Subjectively, scoring can be influenced by the doctor's professional experience in making these evaluations. Doctor-patient interaction, socioeconomic status, as patients might have more difficulties expressing themselves, patient recollecting bias. The last study really raised some concerns about the emphasing and inconsistency in performance status evaluation that complicates drug development, and performance status is commonly used in a major stratification factor in clinical trials. And as far as I know, or we knew in this study, there's no areas of specialization other than oncology that are basing comprehensive medical decision on subjective measures. And why using a functional capacity? Well, these two studies showed that if you had a low functional capacity, and here measured in a 6-minute walk test, you will have a higher disease progression and a higher mortality compared to patients that walked over 400 meters in the first study and 500 meters in the second study. The second study also showed that patients that walked below 500 meters were older and had worse pulmonary functional tests and had a higher complication rate and was admitted to hospital for a longer time. So we had this hypothesis that we would try to use an objective measure of functional capacity to see if that could predict tolerance to first-line treatment in patients with lung cancer. We included all Danish-speaking patients that were referred to our Department of Pulmonary Medicine. And we did this study back in 2018. And only patients that was under suspicion for lung cancer were considered for inclusion. Indicators for suspected lung cancers were suspicious pulmonary infiltrates on X-rays, a booking for a high-dose CT scan, or a bronchoscopy. If these indications were present, eligibility criteria were met, the patients were temporarily included until the diagnosis of lung cancer was historically confirmed. Patients with small cell lung cancer with a limited disease or extensive disease, or non-small cell lung cancer with stage 1 to 4 were included pre-treatment. So patients were excluded if they had received an antineoplastic treatment within the last 5 years, had other cancer diagnoses, including mesothelioma, if they were not ambulatory, or if they were hospitalized with severe acute pain or dyspnea that would inhibit the patient from testing around the immediate time of the diagnosis. Patients unable to follow instruction or with recent events of coronary stenosis or any surgical interventions were also included. So patients were tested close to the time of their diagnosis with a 6-minute walk test. And prior the testing, the patient was screened against the following safety criteria. Heart rate were not allowed to be above 115 beats in rest. Systolic blood pressure were not allowed to be over 180 mils of mercury. Systolic blood pressure were not allowed if it was under 45 or above 95 mils mercury, or if any other criteria were met. The decision of participation on that day were determined on the referring doctor. Patients were then instructed in how to perform the 6-minute walk test following the American Thoracic Society guidelines. Oh, sorry. The 6-minute walk tests were performed along a straight corridor of 20 meters. The patients were instructed to cover the longest distance, by walking back and forth in their own pace for 6 minutes between the two cones, making the lane, and were advised to slow down or rest if necessary. Standardized phrases for encouragement were used every minute. Distance were recorded in meters per minute and when stopped. Complications. Sorry. Finding the controls here. There we have it. Complications were categorized into minor and major complications. Minor complications were graded 0 to 2 in both scales, and major complications were graded 3 to 5. Patients with both minor or major complications were registered according to the most severe complication. Only complications related to active antineoplastic treatment were considered. From February to April in 2018, 45 patients were under suspicion for lung cancer. Of these, 5 were excluded and 19 patients declined participation. Reasons for declining were pain, dyspnea, no time, not interested, or too distressed were diagnosed, though 21 patients were included and completed baseline testing, giving an acceptance rate of 46%. 3 patients were deemed unfit for treatment and therefore excluded from the analysis of complications to treatment. Their main 6-minute walk test for 350 meters. No patients were excluded due to safety criteria or adverse events during the test. 1 patient had elevated blood pressure on the day of testing, but was allowed testing by the referring doctor. Of 18 included patients, 5 had arthritis of the spine or hips or knees. However, arthritis did not influence the 6-minute walk test compared to patients without arthritis. In this study, we found indications with longer 6-minute walk distance, the less number and severity of complications occurred to first-line treatment. The performance status did not reflect the similar association. In fact, the 6-minute walk test was the only variable that shows statistical significance difference between the groups, where performance status, type of treatment, type of testing, pulmonary function test did not show a similar association. However, due to the small sampling size and the design of the study, the p-values must be interpreted with caution. The strongest factor of this study was the methodological consistencies in following standardized guidelines. For the 6-minute walk distance, the same trained professional did all the testing, which was performed on the same corridor, and the same standardized instructions and encouragements were applied. There's no gold standard for evaluating or reporting response to treatment. And since the population received mixed treatment modalities, a combination of 2 recommended guidelines, the Cleveland classification of surgical complications and the CTCAE were applied. Another limitation to the amount of days from diagnosis until initiation of first-line treatment. The intention of testing close to diagnosis was to place it close to their first evaluation of tolerability to treatment, and the course of treatment is decided in the medical department where the cancer is diagnosed. After the initial evaluation, the patient is referred to either surgical or oncological departments for treatment. However, for a more accurate treatment response, the test could have been closer to the time of treatment initiation. The study population present at different stages and treatment modality. It has been relevant to conduct adjusted analysis for confounders. However, we did not have the power to do so. And to conclude and to summarize, there is a trend that a 6-minute walk test is being able to predict complications of first-line treatment, although this should be tested in a larger homogeneous trial. The subjective evaluation of performance status needs an update or replacement of an objective evaluation, and hopefully more patients with lung cancer will get a treatment option. And with that, I will hand it over to you, Christina.
Thanks, Morten. Thanks for a great presentation. And thanks to the International Association for the invitation to speak today. It's really great to get the opportunity to present alongside Steve and Morten today and provide a bit of an overview about the role of psychology in lung cancer prehabilitation. It's raining here this morning, so if it gets a bit loud, that's what you'll be hearing, but hopefully it doesn't impact you hearing me. Next slide, thanks, Audrey. Hopefully today I'll also get to provide a bit of context about the prehab program we have here at Peter Mac to provide some context, I guess, to the role of psychology in this space. So to start off with a polling question, I'd like to ground ourselves in the psychological impact of lung cancer and then come back to the answer in a couple of slides. So if you can answer, pop your answer here, for what percentage of patients with lung cancer report clinically significant levels of distress? Is it more than 5, 15, 25 or 50%? You want to bring up those results? Come back to that. Great. Now I'm just going to take control of these. Hopefully that will work. I'm just going to change the slide. Okay, so just to provide a bit of an overview today, I really want to speak about why psychology is important in lung cancer, why psychology is important in prehabilitation, And I know most people here will be interested in prehabilitation and lung cancer, but I really hope to communicate a little bit about the role of psychology, the psychological impact on patients, and really how psychological considerations are relevant to all clinicians working with lung cancer patients. So, why is lung cancer? Sorry, my slide isn't moving. So why is psychology important in lung cancer? In addition to the medical challenges faced by patients, we know that there are a range of reasons why psychological care should be prioritised in this patient group. And for most of you who answered question D, we'll see that more than 50% of patients will report clinically significant distress. We know that this patient group has a higher prevalence rate of anxiety and depression, greater symptom burden, and is also the patient group with the highest rates of suicide within the cancer population. And there is also significant supportive care needs that are unmet, along with great levels of spousal distress. It's therefore important that this area of patient need is addressed. And in doing so, we can impact a patient's experience of hopelessness and distress, treatment adherence and satisfaction, and quality of life, and improve healthcare costs. Something isn't, Aubrey, unfortunately, my slides aren't moving along. I might need your help with this, Aubrey. Unfortunately, I'm clicking and the slides aren't moving along. But despite the challenges, and wellbeing and psychosocial care remains relatively understudied in the lung cancer population, and this is mirrored in the prehabilitation literature. So what does the literature say? Basically, it's early days, but there's a solid rationale. We know that psychological factors have an impact on surgical outcomes. We know that psychological prehabilitation interventions have been shown to have an impact on patient-reported outcome measures, including psychological outcomes, quality of life, and somatic symptoms. We also have an increased recognition of the importance in psychological strategies in enhancing motivation and adherence to treatments. And there are now clear recommendations that multidisciplinary cancer prehabilitation programs should incorporate a psychological component. And I guess lung cancer patients are arguably a population in great need of access to such programs, given their medical and psychological vulnerabilities. So I'd like to talk a little bit about our model here at Peter Mac, really just to provide context as a way of doing things, not the way of doing things. It's just useful to ground ourselves in, some of the considerations that take part of providing a psychological intervention in the prehab space. So our program involves nursing, medical and anaesthetics teams. There's an educational component that comprises of surgery school and educational materials that were developed by all clinicians, and then an exercise, nutrition and psychology component based on screening, and also really valuable weekly multidisciplinary meetings that are joined by all clinicians. So why take an individualised approach when we're looking at psychological care? Well, I think Steve mentioned the Macmillan stratified risk triangle based on the complexity of patient needs, and our model of care is based on similar ideas. So depending on where a patient falls will depend on what type of care they're provided. And so I guess if most patients fall towards the bottom of the triangle, there's going to be a significant importance placed on education for patients, which we try to address through a range of interventions. And not all patients will require individual support, and that's why there's a key role to screening patients to see who's eligible for this. Macmillan recommends a range of different screening measures, including these measures, but sort of suggests that they're not the only ones that can be used. What we ended up going with is a shorter version of those suggested measures, which is called the PHQ-4, which essentially takes 2 items from both the GAD-7 and the PHQ-9. And really why we selected this in our program was, as it's a validated screening tool for anxiety and depression, we chose it over other alternatives due to its brevity, really, to reduce burden on the patient cohort, because at screening they're also given a number of other measures. But we chose a really low cutoff in order to, I guess, maximise the chance that we're capturing patients who are in distress. And we also make sure that patients can be referred based on clinical judgment at any stage to our prehab or more broadly to our psychology service. And so now a little to talk about what it is that we do and how we do it. I imagine many of you working in this patient group will be familiar with the raft of emotional responses seen in this group of patients. And that includes, but is not limited to, the above. Similar to the tiered model I suggested before, Macmillan talk about the intervention side of things, and Pippa mentioned this as well, being either universal, all health professionals, through to specialists, so delivered by psychologists and psychiatrists. I guess this is really relevant because it demonstrates that all clinicians have a role to play in supporting the psychological wellbeing of their patients. And for those of you today who are not in psychosocial roles, I'd encourage you to think about the ways in which you already do these things, including, I guess, how you contribute to patients' psychological care through effective communication, compassionate communication, identifying psychological needs and addressing those either through referral or through some of the more targeted interventions. And just have a bit of a think about how this applies in the setting that you're working in now. And then I'd like to spend a little bit more time now talking about the specialist end of the triangle, which has been what I've been involved in our program here. So what happens after the screening when a patient gets through to a one-on-one appointment? Well, in our program here at PenMac, what we do is offer a one-on-one session, which is typically about 50 minutes. And usually patients will attend 1 or 2 sessions prior to surgery, sometimes more if there's a greater lead-in, there's some sort of barrier that needs to be addressed or some other delay. And this assessment may include, but is not limited to, the above. So what we like to find out from the patients that we're seeing is what has been their reaction to their diagnosis and the proposed treatments. What's their understanding of the procedure that they're going to undergo, their expectations, and are there any gaps in this information that might be addressed and either reduce anxiety or perhaps help with their recovery window? Is there any anticipation or worry, concerns about pain? How are they engaging with the tasks that have been prescribed by other team members? And are there any barriers that we might help address to maximise their engagement with that? What are their plans to keep themselves occupied before, during and after this treatment that they're going to have? And how can we help them activate their social, emotional and practical supports for this time? Are there any fears that they have? It's also useful as well to ask patients about any history of previous major life events or medical events, and how they coped at this time, as that will give us some indication of drawing on any strengths or addressing any challenges that could arise. It's important as well, I guess, given what we know about this patient group, to screen for mood, anxiety, psychiatric history, and address any of those needs that might arise. And towards the end of the session, really coming up with, well, what is this patient's primary presenting concerns? Are there any barriers to the preparation, surgery or recovery that we might be able to see from this assessment, and how might we address this? And alongside that, identifying what the patient's goals are. And this is just, I guess, a really important point because it's key to engaging the patient. So we want to support the attainment of patient goals and support the team in helping the patient attain goals and address barriers to doing so. And if there are any barriers, understanding why. So what are their beliefs, values, or psychological or practical barriers? So there's a range of interventions that can be drawn on depending on the patient's presentation. And just of note, I guess, if we're only seeing patients once or twice in this pre-surgical window, these interventions will often occur alongside assessment in one session, for example. So one of the things that we can do is provide some psychoeducation on preparing mentally for surgery. We will often help patients with stress management and problem solving around barriers perhaps that might interfere with some of their exercise or nutrition needs. We might draw on behaviour therapies or motivational interviewing if there are particular things that patients want to or need to change to enhance their recovery. There'll be a lot of use of cognitive behavioural approaches around managing worry, depression, mood, fear, concerns. We will also spend probably a lot of time talking about communication, whether that be with their medical team, whether that be with their family, how people can activate and accept support from others. Strategies for maintaining motivation, sometimes scheduling, things like that. And I guess, as I've mentioned, activating supports for the treatment period. In addition to the individual work with patients, I just wanted to touch on the importance of the multidisciplinary team and how psychology has a role to play in this. There's really great benefits of working in a multidisciplinary capacity. And one of the things that I found is that it's gaining a greater understanding of what it is that your colleagues do, which I think is, essential if you're going to support that process. There's also an educational role I think that psychologists can play in helping implement behaviour change more broadly in this patient group. And we can also provide psychological formulations to the team when that's useful. And I think Steve might have touched on this as well, is that it's important that I think all disciplines contribute to the development of resources and education, particularly if not all patients are seeing the specialist clinician one-on-one, so that all patients have access to psychoeducational materials, for example. Finally, I just want to touch on next steps and a bit of a summary. So really the next steps are to build on initial work and early programs to establish an evidence base about the effectiveness of these interventions and components of care. Things we need to consider are how do we optimally screen patients in distress versus, can we make this routine care for all patients? But that's obviously going to be a challenge probably from a resourcing perspective. So to summarise, there's growing evidence about the role of psychology in prehab. And while lung cancer is underrepresented in the literature, it's one of the most vulnerable cancer populations, both physically and psychologically. This gives a solid rationale for the importance of prehab in this space. Psychologists, and indeed all health professionals, have a role to play in addressing the psychological concerns of lung cancer patients, while also supporting behaviour change processes more broadly. Key components to such care include education, assessment, intervention, multidisciplinary work, and coordination of care. And more research and service-based appraisal will be essential in solidifying the importance of this work in this population and in cancer patients more broadly. And here's just a list of references. Thank you.
So thank you very much, Christina. We will now be opening up for questions for the panel. So please, a reminder, if you have any questions for the panel, be writing them into the Q&A section. We won't be checking the chat and we won't be using the raised hand function. So I guess just to kick off, we have one question here for Steve. So Steve, we often hear that patients have to gain weight and eat whatever they want. Is it better that they gain weight even though it is not muscle mass?
It's a very interesting question. It's one that we often hear asked by patients. The preoccupation with weight is perhaps something of, and gaining weight is perhaps the wrong target. I think what we really want them to be able to do is improve their metabolic control and maintain weight, and where possible increase weight. But if you start with increasing weight as your first target, many patients fail to gain weight, and it just adds to further burdens to the patients in terms of the progression of their care. So in our world, we would say that the first target is to maintain weight. It's very hard just to gain lean. There's no simple means of doing that. And gaining weight normally requires a gain in fat and a gain in lean. What we know that happens in many inflammatory states is that it's very hard to gain lean, and many patients just gain fat. And they actually don't improve their functional well-being. So to me, it's about maintenance first. It's about making sure all the nutrients are in, rather than just loads of energy or loads of protein. And it's about actually trying to improve the functional capability of the individual.
Thank you, Steve. Christina, I have a question for you. I think it's really interesting and really important that you highlighted that actually addressing the psychological needs of patients isn't just a role for the psychologist. You know, I think internationally psychologists, you're really understaffed, and it's really challenging. I think, unfortunately, people often are a bit scared, or they tend to shy away from starting to open some of these discussions up, because we can feel a bit sort of, you know, how do I address this? How do I not open the box and leave it open? And what do we do? What advice would you provide to sort of other clinicians on this call about how they can feel comfortable and how can they help to start address some of those needs?
I think that's a really good point, because yeah, we know that there's a huge proportion of patients who will have distress that probably requires some sort of support. But what we know is that probably in a lot of services, it might only be maybe 2 to 5%, say, that get a referral to some sort of individual support. So I guess first and foremost, it's as a clinician in another area is knowing what's available to you, both, I guess, within your hospital and within the community, because that gives you a sense that you don't have to hold it all yourself, you know, that you can hear what the patient has to say and then either be able to offer them some sort of individual specialist support. There might also be helplines, things like that, that are available to the patient. Then I think as well, just trusting your clinical skills. You know, I think everyone will probably be surprised that you just listening, validating, and being genuinely occupying that space with a patient is often incredibly powerful. And so I think as well, trusting yourself with that, that you probably are a lot more skilled than you realize. And I guess if you've got a particular that sounded bad, but it's more skilled in kind of, I guess, psychological work than you realize. And then I guess as well, if you've got a particular interest in this area, perhaps seeking out some additional training, like in that sort of targeted area, perhaps of that triangle around different skills, if you want to develop some extra skills in that area.
Thank you. And whilst we're on you, we've had another question come through. Someone's asked, what do you think about the effect of emotions on gen's expression, so epigenetics?
Oh, I'm not sure that I'm not sure that that's my area of expertise. I can have a look into it, but yeah, that's something I don't think I can answer on the spot.
I don't blame you. I wouldn't be able to either. I've got a question also for Morten. I think it's really interesting to have someone talk about the use of function and sort of the limitations of these, you know, performance status, which, you know, sort of the be all and end all. I guess my question is, we know that quite a majority, I think it's something like 40% of all patients that are readmitted post-operatively are because they're not managing functionally at home. So what was the reasoning behind choosing the 6-minute walk test versus some other form of, you know, assessment for function for the study?
So the reason we used that was due to the 2 studies I showed you that had showed if you walk below 500 meters and 400 meters, there were actually more complications and a higher disease progression as well. And the easiness of doing these tests as well. In a larger randomized trial we are trying to do at the moment, we're also using this hand grip strength, we're using the sit to stand test, and we're using stair climbing as well. So what we really want to do is give the the clinician another tool to evaluate these patients. So hopefully more patients will be evaluated out of function and not out of some subjective measurement of what they're capable of.
Brilliant. Thank you for that. I believe that's most of the questions that we've had come through now. I guess if anyone else on the call has any questions that they'd like to put through to our panelists, I'd encourage you to do so now. I'll just give you a few minutes. Did anyone else, I guess anyone from the panel, did you have any questions you wanted to ask another colleague at all? Well, we've kind of done it. Yeah. Steve?
I think it's as much a point as a question. I think all three of us have emphasised the importance of assessing the patient. And I think all three of us are very keen that we don't focus on research methodologies that are great for trials and for studies, but actually never translate into the clinic. And I think one of the things that came out of our experience in the UK when we were producing the Macmillan report was the importance of multidisciplinary working. I would just like to, you know, as we have three very different skill sets, all very different skill sets on the call, I think it's really important that we encourage all of our colleagues, in whatever setting they're working, is to think about drawing on the experiences and capabilities of their peers. Because I do think that what we're lacking, we're a bit blinded, and we do, blinkered is another way of looking at it. We do tend to approach the problem from our own interests rather than from the patient's needs. And I think the multidisciplinary approach, getting assessments into early MDTs as early as possible in the process is key. And I particularly like Christina's observations of actually getting a very short test, something that we could introduce simply into quite a battery of tests. And I think that's what we're going to be seeing. What I would make a plea for is that we start to look how these tests work in lung cancer. The bulk of the literature, when we've looked at it, is largely in GI cancers, very, very little high quality evidence in lung cancer. And given the nature of the organization today, the International Association, can I make a plea for people working together multidisciplinary wise to start to look at the simple things that we can do in clinical settings and evaluate them in terms of their impact on care. So as much a quality improvement agenda as a experimental medicine. And our experience has been by working together, we can learn a lot from each other and share that learning with all members of the team so they can all contribute to the care of the patient.
Thank you, Steve. And thank you to all of our panelists today. I guess that's all we have time for. So I just want to thank everyone, all the speakers, for joining me today. Please keep an eye out for an email that we sent to you for program evaluation and also CME information later today. And thank you very much for everyone's participation. Thank you.
Thank you very much.
Thank you.